Well, once again, in the spirit of Functional Medicine Update Clinician of the Month, we're very pleased to have a person who will bring to you information that I think can really be used. I have been very impressed both intellectually and, more importantly, clinically by Elaine Gottschall's work. Breaking the Vicious Cycle, Intestinal Health Through Diet is the book that we'll be discussing that she has authored, but beyond that is her contribution as described in the book to our understanding of how to really deal with some of these very complex gut inflammatory disorders and the relationship they have to immunological system activation and even to neurological function. So Ms. Gottschall is very well educated, having gotten her master's in cell biology, looking at a study in the effect of sugars on liver cell function. She's done research towards her PhD in inflammatory bowel disease and has had a very significant contribution through her work and writing to doctors and patients alike, implementing dietary programs that really deliver the goods and improving GI function. So with that introduction, Elaine, we welcome you to Functional Medicine Update, and I guess the first question I always ask individuals is what actually got you into this area of interest and to the contributions that you've made?
Well, it started quite differently than most of your authors, I'm sure. I was a Leave It to Beaver mother in the 60s and doing my best when our younger daughter became seriously ill, first with schizophrenia, and then it was followed up with what was diagnosed as ulcerative colitis. We lived in the New York area and had access to the finest hospitals to which we took her, and the diagnosis was definite. The prednisone, as we all know, works for a little while, stops working, and they were scheduling her at the age of 4.5 to have her colon removed. Now, I realize this is a life-saving operation, but no mother or father wants this to happen to a 4.5-year-old child. So we started looking all over the place. We went to Leahy and Mayo, and everybody was saying the same thing. First of all, food has nothing to do with it, because that was the first thing as a mother I had thought of. What am I doing with her diet that's wrong? Well, no, food had nothing to do with it, and now, 40 years later, it's the same thing. Food has nothing to do with it, which, of course, is not true. We then, fortunately, after 3 years of hunting, found, right in New York City, a 92-year-old, internationally known pediatrician. He had been the first doctor to cure celiac. We found him, and within 3 weeks after going on the original celiac diet, and this had very little to do with gluten, by the way, the schizophrenic symptoms went, never to return. My daughter is now the mother of 2 lovely children and is over 45 and has never had a return of that neurological problem. It took longer for the ulcerative colitis symptoms to abate, but by the end of the year, with a few ups and downs, and with the doctor still hanging in there, he died at 94 2 years later, this child was well. She had grown, had made up for all the lost time that she had been on medication and hadn't been absorbing food right. We were on our way at that point in time. I became very curious. We had her to 15 specialists, the very best in the world, and we found that something as simple as diet turned this whole thing around. So, with trepidation, entered the university at the age of 47 as a freshman, and began with nutrition and realized what I was after had a lot more to do with other things such as endocrinology and immunology and pathology and all those sophisticated things. And although I was frightened, I jumped in. And for the next 12 years, I kept reading the literature and doing the research, and finally, after 7 years of consulting, decided to write my first book, which I followed with the second book, Breaking the Vicious Cycle. It's been extremely interesting. The letters that I get when the phone rings, I never know who's going to be on. As I mentioned to you previously, I just recently received a letter from a Philadelphia mother whose child is getting over Tourette's syndrome, that horrendous behavioral problem where they never know what the person is going to say, and it's erratic and embarrassing. And as we're going to talk later, Jeffrey, we know now, we should know at least with all the literature that's been published, that so many of these disorders, neurological, the dermatology, in fact, some of the problems are starting in the gut. All these things, I would say 100% of all our illnesses, but many of them are starting in the intestine.
Well, that's a wonderful introduction and segue. I think that testament and the value of a book is measured in its timelessness. And Breaking the Vicious Cycle, Intestinal Health Through Diet, is, I notice, in its fifth printing. It's a book, as I mentioned to you, that I personally have gone back to and enjoyed rereading. It's very information-dense. It's written in a style that both the patient and the practitioner can read and enjoy and take away information. And with repetitive reading, you find different texture and different levels of dimension in the book and the writing. So clearly you have contributed to what I guess will be called a classic. It's built around a fundamentally very sound precept. And I think the precept, as I read the book, if I could summarize it, is that 70% of the lymphoid tissue of the body is associated with the gut-associated lymphoid tissue, and therefore what we eat and the messages that our food brings to that gut-associated lymphoid tissue has an impact not only in the localized environment of the gut mucosa, but the generalized systemic response of tissues that respond to immune system activation through the gut. So when you start talking about unique individual biochemical characteristics locked into genes and then eating foods that have a nonsense message to those genes, you start to see the diseases of alarm, which we call inflammation. And that was kind of my very simple metaphor that I took away from the reading of the book. Does that sound to be a system of thought that's consistent with your view?
It certainly does, and it also fits in quite nicely with another appealing hypothesis or theory, which has to do with the autoimmunity and those disorders, including rheumatoid arthritis, etc. What to me is the most appealing theory is the fact that for some reason there is an overgrowth of a certain type of bacteria, and it could vary because they're always mutating down there, which thrives by living on the undigested, unabsorbed starches and sugars. And as a result of some genetic, well, we call them the histocompatibility antigens now, as these bacteria overgrow, for some reason, they bear a similarity to the markers on the intestinal cell. So when our immune system tries to jump in there, and the antibodies and some of the killer cells try to get rid of this overgrowth, because we're supposed to have a harmonious environment down there with many families living together harmoniously, but you now have one bacterium that has overgrown. Well, when the immune system comes in and tries to get rid of this overgrowth, we have the antibodies attacking because of the similarity, or what they call molecular mimicry. And Dr. Ebinger in England has worked on this theory, and I understand it's been worked on now for 20 years. We get the autoimmune reaction where the antibody is not only getting at the bacteria antigen or marker on its cell wall, but it's also attacking the similar marker on the intestinal surface. And one of the things that Dr. Ebinger even published, and I couldn't believe this, in the mainstream clinical rheumatology in '89, he says most of these gram-negative bacteria that he has found that have overgrown will thrive on starch. And he says we get them on a diet, and lo and behold, what did he do? But he quoted all the foods that I allow in my book and eliminated those which I do not. So someone else has evidently come to the same conclusion that if we can starve out this overgrowth of starch and sugar-guzzling bacteria, will get their numbers down to normal, the autoimmune reaction will subside, and many of these other things will fall in line that you had mentioned. So to me, that is a very appealing theory. And the fact is that I wish well to all the researchers who go along their own path to try and find out why the diet is working, because it is working in about 95% of small intestinal Crohn's, about 75% of the colonic problems, whether they be Crohn's colitis or ulcerative colitis. About 25% do not respond, and I wish I knew why, but 75% improve tremendously, and many of them get better. And even though mainstream says there is no cure, I consider a 40-year remission a cure. Thank you very much. But diverticulitis responds. It's one of the easiest to turn around. IBD, irritable bowel syndrome, responds. And then along with that comes all these other wonderful things that are happening unexpectedly to me when babies with diarrhea and epilepsy recover. The epilepsy goes in 10 days. And for a long time now, we've known about that high-fat diet called the ketogenic diet, which Jim Abrahams, the producer in Hollywood, made a picture about recently. We know that diet is quite successful, perhaps in over 50% of the children. Unfortunately, for years they've been trying to find out why would a high-fat diet reverse epilepsy. And I would suggest that it's not the high fat that's doing it, it's the elimination of all these carbohydrates the child has been taken off. So we have all these wonderful perks coming in here. Some of the skin diseases are clearing up. My own child had a nighttime type of schizophrenia, and I've heard from many mothers whose children were sleepwalking along with their diarrhea conditions, and the sleeping pattern becomes normal again. There is something happening down there in that gut. I'm not sure I know exactly what it is, and I wish somebody would do some really good research, maybe 10 labs working at it at the same time, and try to really decipher what is going on.
Well, like your book, that last discussion you just shared with us is very information-packed. There are three areas that you immediately triggered in my mind, so let me kind of back up for a second, see if I can't check in on those. First is your concept that there are these mimicry reactions going on between different kinds of flora in the gut, dysbiotic flora, and the gut immune system. And this sounds very similar to what Dr. H.O. Hunter calls intrametabolic disorders, which I know you've described in your book.
Right.
Could you give us a quick description as to how you see the intrametabolic disorder connection related to your diet?
He is saying that what is happening is not purely an allergy reaction, if I remember Hunter's paper exactly. He said that we are not getting the kind of response you get in a typical allergic reaction when you have these gut problems. You don't have your antibody IgE performing as it normally does. Some of the other things which I've forgotten in the last 10 years that happen in a typical allergic reaction. He said what you have here is an intermetabolic digestive problem, an overgrowth of the bacteria that I talked about. And as far as I can remember, that's how he goes about it. I have his paper lying around here at my...
Yeah, actually, I think you hit a beautiful summary. The title of that paper, as I recall, is Food Allergy or Intrametabolic Disorder?
Absolutely.
And so he's questioning whether, as you say, these reactions are true food allergies, because a lot of allergists are saying, well, that's not an allergy. And what he's saying is, hey, the symptoms are there. It's not an allergy, but it's a toxicity reaction, just as you've indicated.
You brought it all back to me. Interestingly enough, Jeffrey, and I know the allergists deserve tremendous amount of credit because weren't they the first ones 30-some years ago who started bringing attention to food and all these problems. But I lately have been getting more feedback from some of them. A lot of the allergic treatments, the desensitization, the elimination of certain proteins are successful, but when they do not prove successful, I've been hearing from some of them, and in fact just was invited to speak in September of '98 at the British Society for Allergy, Environmental, and Nutritional Medicine. So they're looking, it seems as though they're looking for answers too. We all are. So I will be there, with God's help, next year and present this theory or hypothesis to the allergists.
Very exciting. Let me move to the second question that came from your discussion, and that is the ketogenic diet relationship to epilepsy and your very provocative hypothesis. I know that Dr. James Brawley, who has been very active in the allergy field for some time, I think put out a press release right after that movie played on TV in which he said, very similar to you, that positive impact of this diet was not due to the fact it produced ketogenesis, but it was his belief that it was because it was a low allergy diet. And I think you're going even a step farther, saying it's not just low allergy, it really...
low carbohydrate.
Right.
And I've spoken to Jim Abrahams on the telephone, and someone had sent him my book before he made the movie, and he said, I kept asking the doctors before they found the answer for Charlie, why do all these kids have something wrong with their gut, whether it's severe constipation or diarrhea? Evidently, he was brought in contact with hundreds of parents with children with epilepsy, and he found out, indeed, they had gut problems. Again, I'm terribly excited about the idea that it isn't the fat, it's the carbohydrate, because I know some of them are not getting completely well. And I realized when I looked at the ketogenic diet, in order to prevent ketosis, they will introduce a bit of carbohydrate. They're not being careful enough, in my opinion, about which carbohydrates they're introducing. They'll say applesauce, but they don't say applesauce without sugar, or we make it in the book with honey, and there's a difference because the honey molecule, of course, requires no input from the digestive tract, whereas the sugar molecule does, but that's getting into the technicalities of it. I wish they would be a little more careful when they are finding the child is developing ketosis, which a person will if they burn only fat for energy, that they introduce the right carbohydrates, and that's what I would hope for. I hope somebody picks that up and does that. That's not going to be difficult for them to do instead of giving them a tablespoon of maybe ice cream that they give them some mashed banana or some homemade ice cream, which we have recipes for in the book.
Well, let's move to that. Let's move to the diet program now that you just define in the book. And as you indicated, that you really spend quite a bit of time in the book very eloquently describing different kinds of carbohydrates, simple and complex, and the relationships they have to GI function and immune system function. You make a differentiation between amylose and amylopectin, with most starch being the more highly branched amylopectin. Yet the literature that I see recently coming out is that amylose-rich starch, which is resistant starch, may be more gut-friendly in that it tends to help to nourish the friendly bacteria in the colon, which then are able to competitively push out the parasitic bacteria by leading to more short-chain fatty acid production and reacidifying the colon. So,
okay, well, I had always felt that the amylose was more gut-friendly because it has a very simple molecular linkage. The amylose in biochemistry has the sugar molecules attached by what we call a 1,4 linkage. In the intestinal tract, even when you're sick, there is some activity from the digestive enzymes there that are lining the mucosa to break apart the alpha 1,4 linkages. As you see in the book, I drew the picture of what the amylopectin molecule contains, and it has a lot. It's like glycogen, in fact. It has not only 1/4, but has 1/6, and even in healthy people, biochemistry textbooks will tell you that there is a very limited kind of enzymatic digestive activity for 1/6. That's the isomaltase linkage. I wish I had all the answers for that because I spent 2 years using the different kind of starches with the rats to try and figure out what was going on, but unfortunately rats don't respond the way human beings do. But no, I do think that the amylose is more gut-friendly. The fact is, I don't necessarily want it to feed bacteria. What I want to happen is, because it is easier to break apart, then it will be absorbable. What I would like to do, and what I say in my book, is to optimize the digestibility and the absorption for the individual and make it less for the bacteria, because what we're trying to do is to decrease their numbers. And for some reason that no one understands, when we use this diet, they change in type as well. From the standpoint of it being more gut-friendly, it is, to me, easier to digest, and therefore, once it's broken apart, that amylose linkage, then those sugar molecules will go into the gut, into the bloodstream through the gut, and nourish the individual and give them the calories and energy that they need. So from that standpoint, I've always thought that it was one of the reasons why some of the things were allowed in this diet in the way of carbohydrates. But unfortunately, my results in the research weren't as conclusive as I would like them to be. You see, this was not my diet, Jeffrey. What I did after my little girl was cured was to go on a treasure hunt for 12 years. This wonderful doctor, Dr. Sidney Valentine Haas, who cured her. And by the way, I'm collaborating on writing a book about him and the real cure for celiac. I'm collaborating with Ron Hoffman, writing a book on celiac. What he did was give us this diet. We saw the schizophrenia go away. We saw the ulcerative colitis go away. And I went into that university to find out why. 2 questions. Why did the diet work? And secondly, why was he the only doctor out of 15 that told me that diet was important? So unfortunately, I got into the politics of food as well as the biochemistry of food.
Mm-hmm. When I look at the diet, I notice you've made a very nice distinction among monosaccharides, disaccharides, and polysaccharides, the amylopectin, amylose, polysaccharides.
Right.
Which one of those families do you find is most problematic as you have formulated the diet?
I think that the combination of the amylopectin starch along with the gluten that you find in most grains, it isn't just wheat and rye that have gluten proteins in them. You know, have corn has more gluten than wheat, including the alpha-gliadin fraction. Rice has a gluten-like protein. I find that the combination of the amylopectin starch and the surrounding network of the gluten protein in grains is the most problematic of all things. To me, rice and corn are most deleterious of anything that these people can eat with these gastrointestinal and behavioral problems. Wheat certainly should be taken out. There was some wonderful research, which I cited in the book by Dr. Levitt, I believe, where he removed the gluten surrounding the starch of wheat and put it back into the bread separated from the starch and found out that it had no deleterious effect. It's the juxtaposition, the close relationship physically of the starch surrounded by the gluten fence, and the pancreatic enzymes cannot get to that starch, whether it be amylose or amylopectin, to break it apart. So what it does, see, the gluten is preventing that. So what it does is goes down to the lower intestinal tract, the ileum and the colon, and the bacteria down there can do anything. They can break that gluten out and get to that starch. They want that starch, most of them. That's what they live on. And they can get to it. A lot of the work on gluten has relevance to it. I just differ in the idea that it's an allergic kind of problem with the gluten. I think it is a digestive problem with the gluten. It is preventing the digestion of starch.
Oh, that's a very interesting observation.
And Levitt, as far as I know, and I've cited him in my book, he's done wonderful work on carbohydrates through the years. He did this very simple experiment and showed that he did not believe it was the gluten per se.
You must be very excited to see that agriculture is now moving to form new cultivars of starch and vegetable protein producing plants that are lower in amylopectin, higher in amylose, and lower in gluten. I noticed that there's some new cultivars, for instance, of rice that are very low in gluten, in fact, gluten-free.
Well, I apologize for not reading that literature, and I sure would like to get my hands on it. The fact is, when they say low anything, it's like the pill that they were given the women to prevent pregnancy, It's lower than it was. It's not low. In other words, the estrogen in the pill is still too high in my book. So I don't know what they mean by low. It must mean lower. Why, maybe 1% or 2%. I'm not excited about what agriculture is doing with this genetic breeding at all. I'm very upset about it because nobody knows what's happening. For years agriculture wanted to raise the amino acid that was lacking in wheat, the lysine. And nobody worried about what was happening to the digestibility of the protein in the starch. I personally don't know, but I think that one of the reasons that people have so much trouble with wheat may have come from some of that genetic breeding. As we well know now, this is the name of the game right now. So I can't keep up with it, to be quite frank with you. I think I could spend the next 10 years in the agricultural library in an effort to understand what's going on with these new crops that they're cultivating.
Well, I know that in your book you talk, and I think it's a very good recommendation to the reader, that you need to take this diet very seriously. You need to have, I think you call fanatical adherence to it to really get full benefit. It's not just something you dabble with. You really need to make the commitment.
I don't understand why that is so, other than that we're playing around here with the growth of bacteria and yeast, which require just pinheads of things to keep them going. But I know that the original doctor, Dr. Haas, when he wrote his book on celiac, and he used this diet, cited the example of a child most children who were recovered in a year, who were well, and could go back to the so-called normal diet with some intelligence, not what people are eating now, living on French fries and pasta. But he said they would recover, and the only children that didn't recover in a year, the most who were those who infringed occasionally. One child had a grandmother with a candy store, and they couldn't get this grandmother to stop showing her love by giving this child a piece of candy every time they visited. And this child was on the diet 10 years and didn't completely recover. The infringements do delay recovery, and I try to make that very clear.
Let me, if I can, close, because we're in the last couple of minutes, by coming back to the association of the diet with remission of some of the neurological symptoms, which I think is, for some of our listeners, quite a remarkable connection, the gut somehow to the brain. But in the way that science has evolved, that's actually not that remarkable. There are gut hormones that are actually brain neurotransmitters, and the relationship between gut and brain is very tight through immune system activation and the glial cells in the brain. You talked about gluten sensitivity in certain forms of schizophrenia. You talked about Tourette's and multiple sclerosis. In The Lancet recently, there was an article which we reviewed, I think in 1996, on celiac disease and its relationship to presenile dementia. There's a very strong statistical relationship suggesting some gut toxicity with celiac related to brain function. Could you summarize quickly your vast experience as it relates to neurologic function and some of these gut?
I have accumulated probably 20 or 30 research papers that were published around the early 1990s and 1980s, whereby Yale University actually isolated what they thought was the tiny molecule that was coming from the gut that was causing behavioral problems. This work resulted from the fact that for about 10 years, people who were morbidly obese were having their small intestine put out of whack, so to speak. They didn't cut it out, but they shortened it. In a few years, about 40% of them began having neurological problems. They would act as though they were, some of them acted like Tourette syndrome. Some of them acted as though they were inebriated. After this was reported to many emergency units, their spouses and friends were bringing them to when this occurred. They did some work and isolated something called D-lactic acid, which the liver cannot change to the usable form. And so whether or not it is an allergy along the lines that you talk about, Jeffrey, or whether it is actually a small toxic molecule, which only has 3 carbons in it, lactic acid is very small, which somehow gets into the brain, changes the brain cells, changes the pH perhaps, changes the environment of the neurons. I don't know. But there has been a lot of work that has gotten down to the molecular level to show that when you have excess fermentation in the lower part of the gut, and that's what these people who had the operation were having. They couldn't digest anything. That was the purpose of the operation, to eat your cake, have your cake and eat it too, or whatever it is. What is that quotation?
I think you got it right. That was good.
Is that right? But anyhow, something has to happen down in the colon if you don't absorb all that stuff. And what was happening was there was excess fermentation, and the neurological problems showed up, along with arthritis and a few other autoimmune disorders. And Yale did some nuclear magnetic resonance isolation of what they identified as a D-lactic acid molecule. Now, there must be more work after that. There were about 20, 30 papers published dealing with this phenomenon after the operation for obesity. So whether it is a typical allergic reaction or whether it is a toxic product such as D-lactic acid, I don't know. But there is good, solid work done by many labs to show that there is a connection.
Well, Elaine, I want to thank you so much. Elaine Gottschall's book, Breaking the Vicious Cycle, Intestinal Health Through Diet, I believe should be in all of our libraries and part of our therapeutic armamentarium. And Elaine, I'd like, if I could, to give the 800 number where people can order the book, 800-332-3663, and that number will be on your summary cards at the end of this month's tape. Or if you're out of the United States, you can check into the World Wide Web, and I'll give you the worldwide website. It's SCD-list at Long Island, that's one word, L-O-N-G Island, ISLAND.com. And again, that will be at the end of the summary cards as well, so you can check in and find how to order the book over the web. And Elaine, I want to thank you for this very, very stimulating discussion that we've had over the last half an hour, and I hope that it's turned many of our listeners on to utilizing your concepts in their own practice.
Thank you so much, Jeffrey. It's been a pleasure.
It's been my pleasure. I'd like to follow up with a few closing comments about Elaine's discussions concerning the intestinal health and dietary connection. Some interesting papers have appeared recently that might help fill in a few of the things that we were discussing in greater detail. First of all, what about bacterial endotoxins that come from gram-negative bacterial cell wall debris like the lipopolysaccharides? What impact do they have upon Kupffer cells in the liver and the mucosal cell immune system? Well, they activate, as you might expect, the Th1 cytokines, the pro-inflammatory cytokines like tumor necrosis factor alpha and interferon gamma, interleukin-1. This subsequently then decreases hepatic oxidative enzyme capacity related to the cytochromes and modifies then synthesis of complex hormone precursors and also reduces then the activity of detoxification. This was found in some very interesting animal studies published in the journal Lipid Research, volume 38, page 1620 in 1997, in which it was found that endotoxin actually increases TNF and interleukin-1 and decreases thereby complex cholesterol derivative synthesis like hormones and suppresses isoforms of cytochrome P450. This ties very nicely together with some of the clinical work that Dr. Mitchell Kaminsky talked about as the Clinician of the Month last month in our October issue of Functional Medicine Update. Second, what about the role of nonsteroidal anti-inflammatory drugs, NSAIDs, in influence on gut mucosal activity? I think every one of us recognizes that NSAIDs produces a pro-inflammatory state upon the gut mucosa, increasing gut permeability and providing an increased opportunity for leakage by pericellular and transcellular absorption of various larger molecules that can then have an effect upon immunological activation. Recently, in Carcinogenesis, there was another paper talking about the effects of NSAIDs on glutathione transferases in the digestive mucosa. And it turns out that the NSAIDs seem to increase inflammation, which then increases the load of toxic substances and increases the need for detoxification enzyme systems to be activated in the gut mucosa, so that glutathione transferases, which is the enzyme involved with the attachment of glutathione to a xenobiotic to form a mercapturate, are upregulated, so that there is, by altering gut mucosal integrity, increased leakage of toxic substances, increased then need for detoxification of substances that are now absorbed through the various phase 1 and phase 2 detoxification pathways, including glutathione conjugation, glucuronidation, sulfation, acetylation, methylation. What about gut flora-associated biomarkers then of neoplastic changes or of alteration in colonocyte activity or in the mucosal cell activity? Are there any laboratory tests that can be employed? And the answer is yes. One of the most important is the beta-glucuronidase test of measuring the activity of the enzyme beta-glucuronidase in the stool. Beta-glucuronidase is an enzyme secreted by toxic bacteria that then cleaves off the glucuronic acid that was so fastidiously put onto toxic molecules by the liver to detoxify them. And it can liberate then in the colon to produce in situ carcinogens when beta-glucuronidase activity is increased. One of the most exciting things is that if you have a comprehensive stool analysis on a patient and it shows elevated beta-glucuronidase activity, within a period of as short as a week, by dietary manipulation with the so-called 4R program, remove, replace, reinoculate, repair, one can lower glucuronidase activities, showing benefit on improvement of fecal flora and colonic environment. One such paper is Nutrition and Cancer, Volume 27, page 250 in 1997, talking about high and low risk diets and the relationship to gut flora-associated biomarkers of colon cancer, the increased beta-glucuronidase activity. In this particular study, they showed that the high-fat, low-fiber, high-refined carbohydrate diet increased in beta-glucuronidase, whereas a diet that's higher in unrefined carbohydrate, lower in fat, and rich in fiber, particularly fibers such as those of the fructose oligosaccharide family, like inulin, lowered than the beta-glucuronidase and purportedly had a lowered risk to colon cancer. We know that one of the benefits of these undigestible carbohydrates found in fiber is that they can be fermented by favorable bacteria or friendly bacteria in the gut to produce short-chain fatty acids such as acetate, propionate, and probably most importantly, the 4-carbon atom fatty acid, short-chain fatty acid, butyrate. Butyrate is a very important substance that is used by the colonocyte as a fuel produced by gut bacteria by fermentation of non-digestible carbohydrate. It is also very important as an anti-cell transforming agent, so it helps to keep genes in order, so to speak, in the colonocyte to prevent the upregulation of oncogenes, and therefore short-chain fatty acid production in the stool of the friendly type, the acetate, butyrate, and propionate, are very important. Oral administration of short-chain fatty acids has been seen to reduce the intestinal mucositis in animals that were fed diets that were highly purified and tended to increase the inflammatory cascade. So if you look at animal diet research, it does seem to indicate that either oral administration directly of short-chain fatty acids or the in situ production by supplementing with a diet that is rich in the 4R stimulating nutrients can produce beneficial effects. Butyrate acts as a apoptotic regulator in human colonic epithelium cells, depending on the presence of alternative energy sources, and therefore the work that's now being published indicates that butyrate has a very important role to play in cell cycling, cell regeneration and turnover in the colonocyte, and the removal of garbage that is related to damaged cells and the replacement with new cells. I think we should really be putting butyrate up on the marquee of very important agents in the stool and in the colonic environment to help nourish proper mucosal function. We also recognize that in cases of gut inflammation induced by food allergy, endotoxins, or other xenobiotics, that there's an increase in the fecal matter of pro-inflammatory prostaglandins, like the E-series prostaglandins or the F-series prostaglandins. These could be F2 alpha, for instance. And by measuring E2 or F2 alpha in the stool, one can determine the relative inflammatory status of the bowel. Recently, it's been found that consumption of diets or agents that lower inflammation will be seen as lowered excretion in the stool of prostaglandin E2 or prostaglandin F2 alpha in individuals who have low or underlying gut inflammation. And by the way, this is found with low-dose aspirin therapy. As you know, low-dose aspirin has been associated with lowered incidence or risk of colon cancer. And if you give low-dose aspirin, you will be able to demonstrate lowered fecal excretion or colonic mucosal prostaglandins E2 and F2 alpha. And therefore, one can use this as a marker to examine the role that various agents have on establishing proper balance between inflammation and anti-inflammation in the gut mucosa. Journal of National Cancer Institute, Volume 89, page 1152 in 1997 discusses that. We know that Lactobacillus acidophilus and bifidobacteria, as part of the 4R program, can help to replace and reinoculate friendly lactic acid-producing, tropic-producing bacterium that are the facultative agents within the gut that would be considered symbionts and favorable inhabitants of our flora. The Nutrition and Cancer Journal, again, has two interesting reports, one on the non-lipopolysaccharide component of Lactobacillus acidophilus stimulating the production of tropic factors from murine macrophages, and also another paper on bifidobacteria as a lactic acid-producing intestinal bacterium inhibiting colon cancer and modulating the intermediate biomarkers of colon carcinogenesis, looking at various kinds of biochemical markers for colon carcinogenesis, showing that they are lower after supplementation with bifidobacterium, just as the immune system is modified or improved after the supplementation with Lactobacillus acidophilus. So it's the use of both the prebiotics like inulin, fructose oligosaccharides, and resistant starch, and the probiotics like acidophilus and bifidobacteria, along with the appropriate nutrient density to help replenish the gut with butyrate, L-arginine, vitamin E, and pantothenic acid. Even Helicobacter pylori infection of the upper GI might in fact be benefited by supplementation with various types of phytonutrient-rich foods so as to lower the potential of infection. I'm now quoting from a very interesting paper looking at susceptibility that Helicobacter pylori has to allium sativin extract. This would be garlic, again coming back to our phytochemical story. Gastric cancer, as you know, has been associated with chronic infection with Helicobacter pylori, just as peptic ulcer disease has been associated. This is a bacterium implicated in the etiology of stomach cancer. We know that allium vegetables, particularly garlic, have been demonstrated to have in vitro antibiotic activity. Standard antibiotic regimes against Helicobacter pylori are frequently ineffective in high-risk populations, and therefore investigators at the Department of Public Health and the Cancer Prevention and Research Division at the Fred Hutchinson Cancer Research Center have recently been looking at dietary principles that help to reduce the infection with Helicobacter pylori, and one appears to be an aqueous extract of garlic cloves, which contains various sulfur compounds which seem to be very useful in reducing infection or replication with the bacterium Helicobacter pylori. I certainly don't want to say that this is an alternative to triple therapy, but rather it indicates that there are food and phytochemical substances that may influence the rate of recontraction or the environment by which a opportunistic organism infects the gut. I think it's important to recognize that all of us are probably exposed in our lives to a Helicobacter pylori. Not everyone gets an infection with the organism. It depends upon their cell surface attachment or adherence to the bacterium, their secretory immunological defense systems, their hydrochloric acid secretory ability, and presence of other factors which contribute to immunological recognition and defense against Helicobacter pylori. So it's a lot like the genes and environment condition that we've heard for many disorders. Yes, you might have a genetic propensity, but it can be modified on the basis of the environmental factors of diet, lifestyle, and exposure. The organosulfur compounds found in garlic, therefore, may have a very important role to play in helping to protect against aspects of infection. When I say infection, I really mean gastrointestinal infection. We also recognize that these same compounds found in garlic may play a role in modifying oncogene expression as well. Compounds such as S-allylcysteine and S-allylmercaptocysteine, which are known to be present in the sulfur compounds in garlic, have been shown to be modifiers of prostate cancer cell glutathione and polyamine concentrations. This work seems to add additional support to the body of work in animals and cells showing potent effects of garlic in the inhibition of tumorigenesis. Again, we don't know the exact dose-response relationship, but there seems to be an ever-increasing body of literature supporting the fact that this wide family of sulfhydryl compounds present in garlic have a very beneficial effect on reducing the expression of tumor genes and for modifying factors in biochemistry that lead to tumor expression. We know that garlic increases both putrescine and increases the glutathione levels, and therefore suggestion is, at least in the use of human prostate carcinoma cells in culture, that this garlic extract has beneficial effects in lowering its replication. Cell-specific reactivity based upon the fact that cancer cells have a different redox potential than do normal cells. And by the way, there is some interesting clinical chemistry information coming available now suggesting that the free prostate-specific antigen, or PSA, is more important than total PSA in a prognostic marker for both benign prostate hypertrophy and for prostate cancer. So you might start looking at the differentiation between free PSA levels. Sounds reminiscent of the difference between total thyroid hormone and free thyroxine or free triiodothyronine, because much of that is bound and is not physiologically active. So looking at free PSA levels and also looking at total prostate volume by various kinds of imaging technology are being used now to track relative risk and prognosis and follow-up on intervention in prostate risk individuals. Dr. David Heber from the University of California, Los Angeles Center for Human Nutrition has written an interesting editorial on organic sulfur compounds in garlic and their relationship to cancer. This was in the American Journal of Clinical Nutrition, volume 66, page 425 in 1997, in which he talks about that this large number of different plants, which include garlic, Chinese chive, Welsh onion, turfstone neck leek, and shallots, all may have very profound influences to provide these phytonutrients or phytochemicals that modulate immune function and gene expression. Garlic was consumed both as a food and as a medicine in the ancient Middle East and in the earliest Chinese dynasties. It's been extensively investigated both scientifically and clinically, with well over 1,000 papers on garlic and related alliums that have been published in the last 20 years. The intact cells of garlic contain an odorless sulfur-containing amino acid, alanine, S-allyl cysteine sulfoxide. When the cells are crushed, as we know, they become in contact with the enzyme alanase, which then converts alanine to allicin, which then goes on to a whole series of other compounds. So it depends upon the way the garlic was formed and how it was prepared in the foods or in the supplements as to what types of compounds are present in the final product and the role they might have as modulators. But certainly fresh garlic, chewed and masticated properly, delivers a whole array of compounds which seem to have, again, phytonutrient protective characteristics. So in close, I think we have covered a variety of topics this month which relate to gastrointestinal health and the interrelationship that has then to immune, inflammatory, and neurological symptomatologies. And again, I thank Elaine Gottschall for her very fine contribution. We will see you next month, December 1997.
Functional Medicine Update is copyrighted by HealthCom International Incorporated of Gig Harbor, Washington, USA. Reproduction in any form is prohibited.